Good afternoon, or good morning, or good evening, everyone. It is my great pleasure to welcome you all to today's webinar. It has the title Implementation Science in Low and Middle Income Countries with a focus on health equity. My name is Nurel. I'm a clinical and implementation research scientist, and I'm working at the Swiss Tropical and Public Health Institute. So I'm very excited about today's webinar and to have the insights and experiences from someone who is very experienced both in implementation science as well as in the particularities of implementing health interventions in low resource settings. Because I think that where resources are low and health needs are high, this might be among the places where effective implementation research can have the greatest impact. That being said, it is my great pleasure to introduce you to our presenter today. His name is Kunle Alonge. He's a professor of global health and implementation science. He is the director of the Sparkman Center for Global Health at the University of Alabama at Birmingham in the US. And he's a leader in global public health education, research, and practice in partnership with both with academic institutions, governments, and non-governmental organizations in different countries. And his aim, or among his aims, is to achieve health equity and address solutions to help problems that mainly affect vulnerable populations in low resource settings around the globe. Before we start with the presentation, I would like to remind the audience that it's possible to ask questions also. I would like to ask you to put them into the chat, and at the end of the presentation, we will have some time to answer these questions. And with that being said, it's my great pleasure to hand over the floor to Dr. Alonge. I'm very much looking forward to your presentation. The floor is yours.
Yeah, thank you so much, Aita. It's really a pleasure to be with the network, the Impact Network today, and to be talking about implementation science, particularly paying attention to communities in low and middle income countries, but not just low and middle income countries, but looking at low resource settings that abounds in every countries of the world. So without any further ado, I'm just going to dive straight into the presentation, and I'm going to share my slides. Okay, great. So today I have two major objectives to accomplish today. I'm sorry, I may not be able to see you as I'm talking, but like Aita said, I will be happy to entertain any question, even if you want to stop me in the midst of the conversation. Hopefully we'll have enough time to discuss extensively at the end of my presentation. So for today's presentation, there are two tasks that I would really like to accomplish. One is really to describe what implementation research looks like in low resource setting. And when I say low resource setting, even though we are focusing a little bit more on low and middle income country setting, but I'm aware that low resource setting abounds also in countries that we would classify as being high income. And some of the features that characterizes low resource setting, it includes things around lack of economic resources, lack of technical resources, lack of infrastructure, and so on. And while these is more common in countries categorized as low and middle income country setting, but we have pockets, even in high income countries, where some of these characteristics abound, including here in the United States. And there's a lot of similarities in how you would approach implementation of a biomedical intervention, be it at the clinical level or at the community level or at the policy level, across these similar settings. So again, a lot of the examples that I will talk about today, we cut across low and middle income country settings, but it would also be applicable to low resource settings in high income countries. So we'll describe what implementation research looks like in such context, and then talk about some of the strategies to overcoming the challenges of implementing, interventions or doing research around implementation in such settings. And then the second goal is really to talk about how we can use implementation research to address health inequities in low resource setting. So of course we are interested in low resource setting because fundamentally we're actually interested in equity. For us to pay attention to vulnerable population, to pay attention to places where there's a lot of need based on the lack of resources is also another way of saying that we're interested in addressing inequity. So whether we say it explicitly or not, almost invariably when we are working in implementation to address disadvantaged population, working in implementation to address vulnerable populations, or doing research around that, we are going to be addressing inequities in some way, or we're going to be interrogating inequities in some way. So if we are purposeful in the way we do it, then we can help mitigate inequities. But if we are not, then we can unfortunately worsen the inequities that may affect the population that we care for. So we'll talk about what are some of the things to pay attention to when we conduct implementation research in low resource setting in a way to bridge inequity gaps. So I will not belabor this because I presume that we've been, as a network, there's been a lot of discussion around what implementation research is. I can imagine that there has been previous presenters that would have come to describe the nature of implementation research, its definitions, and what makes it unique, and so on. So what I would like to just do today is to highlight principles, that is, philosophies that undergirds what we call implementation research, and how we have kind of distinguished it from other kind of research, other kinds of biomedical research, other kinds of health research, other kind of social sciences research, and so on. So implementation research, it's really this notion that we know what works. So it's premised on the notion that we know what works. That is to say that some studies have been done, or there is some knowledge of what works that we've already attained. And the question is, how do we take such things that work, how do we take them to their effect? How do we take them to making impact in a way that is noticeable, that it make a difference for population? So implementation research does not place emphasis on efficacy of intervention. In fact, it comes up further down the pipeline. That is to say, some studies have been done to establish the efficacy of some intervention to address a specific health problem. And so the knowledge of how to implement such efficacious intervention is really what implementation research is focused about. And in that sense, it's also aiming to achieve impact. And there is no achieving impact without doing such implementation and the research around such implementation under real world conditions. So for instance, what I control in my experiment does not guarantee that I will have large scale impact when I take it to the population, unless I look at how the evidence-based or evidence-supported intervention that I've already established efficacy for really plays out within the real-world conditions. So for instance, if I know that a therapy, let's say misoprostol, helps to mitigate bleeding under a control setting, I would have to really do it among healthcare facilities in different settings for different populations to be able to see how it would achieve the impact. So again, implementation research focuses on questions around implementation. It should be done under real world condition, that is, under the routine settings that care is provided or the services are organized. And the emphasis is really on the question of not what works, but it's really on how and why what works leads to impact. So it's really try to unpack that impact pathway for how an evidence-based or an evidence-supported intervention leads to impact. And therefore, it should be fit to purpose. That is to say that there are going to be different implementation problems that you might encounter as you go from one setting to another setting. And therefore, implementation research should be heuristically defined based on the implementation problem that is peculiar to the setting or the system that you're working. For instance, the health systems in Nigeria is going to be different from the health system in Switzerland, is going to be different from the health system in the United States. And the implementation challenges to doing an evidence-supported intervention across different diseases is going to also be different as you move from settings to settings. So your research, your implementation research should acknowledge such diversity, and it should be fit to address the implementation problem that is specific to your setting. And so for you to be able to do that, it's very difficult for one person to embody all of the knowledge there is around the implementation problem in a given setting. You need people who know the context. You need people who know the system. You need the people who know the methods. You need people who understand the communities. If you're working in community setting, you need people who understand the healthcare delivery system. If you're working in hospitals, you need people who understand the policy environment and so on and so forth. So implementation research by default, it should be multi-stakeholder. It should be multidisciplinary. It should involve collaborations. It's a teamed, it should be a team effort for it to actually deliver on its promise. So again, this is another way of saying what I just described. Typically, in our research, traditional biomedical research, be it efficacy trial or even some of our effectiveness trial in clinical medicine or in public health, we're always interested in what works. We're always interested in making new discovery. Oh, this particular factor has a pharmacological property, can ameliorate hypertension and so on and so forth. So, and oftentimes we do that under very stringent control setting because we really want to be able to isolate the effects of that factor that we are interested in. So the what is the evidence-based intervention. That's the EBI on the left side of my slide, and the EST, evidence-supported technology. So oftentimes that's focusing on discovery. And our traditional research really control all of the controllables, controls the setting, controls the population, controls the strategies in which some of these EBIs and ESTs are delivered in order to be able to isolate their efficacy as they influence specific health outcome. And that's the usual. But when you now take that and you want to take that into real world condition, oftentimes we miss the point because we really did not study all of those interventions within those real world conditions. So that's really what implementation research begins to unpack for us. So implementation research focuses on the how, that is, what are the different strategies for delivering your evidence-based interventions for different population groups within a defined setting. What are the outcomes that are really very proximal to your implementation strategies? That is to say, outcomes that can tell you whether or not your implementation activities are successful and as distinct from outcomes that you can use to learn about the effectiveness of your intervention, that is the clinical outcome. So these are implementation outcomes such as acceptability. That is to say, if I go back to the example of the misoprostol, if I know that misoprostol works to control bleeding, but for me to be able to see that clinical effect, that is reduction in mortality and morbidity due to postpartum hemorrhage, for instance, some woman has to find it acceptable to administer misoprostol when they give birth to their baby. So again, acceptability in that sense helps me to see whether my implementation arrangement is successful, and therefore it can mediate the outcome, the health outcome that you would expect for the intervention that you are delivering. So that's some of the ways by which implementation research helps us to understand the how and the why, and to unpack the pathways through which our interventions leads to an outcome. And all of this is happening within context. So unlike other traditional research, including our efficacy research and our trials, clinical trials and so on, where we try to control the context to some extent, in implementation research, we're actually interested in the context. And that's really why sometimes there is always that tension between making sure that we are doing things in diversified contexts so that we can learn across different settings, so that we can actually tell the story of how intervention leads to impact, and balancing that against internal validity, that is doing things in a very rigorous way so that we know that our methods are sound and that we've done things in a very systematic fashion that allow us to learn something independent of the context. So there's always that tension between internal validity and external validity when we're looking at implementation research for those who are epidemiologically inclined. But oftentimes implementation research tends to prioritize external validity, given that there is some consideration for internal validity to establish the evidence of the intervention. And this really formed the core of implementation research. That is to say, there is emphasis on implementation strategies. That is the how we facilitate an evidence-based intervention. There's emphasis on using implementation outcomes to study whether or not implementation research, our implementation activities are successful. And there's also emphasis on implementation context, understanding the context in which we are delivering, conducting our implementation. And context could mean context within which the implementers are working, or the organization that is implementing is working, or the context could also include things pertaining to the beneficiaries of the intervention and the community in which, or the clinical services setting in which the intervention is being delivered. It could also include external context, including the politics, the economy at large, as it affects those organizations that are either implementing or benefiting from the implementation. So again, implementation research emphasizes study of implementation strategies. It uses implementation outcomes to learn about implementation. It also unpacks the context and study how context really varies and how it kind of impacts implementation pathways. And lastly, for you to be able to do all of these, then you really need to be very pragmatic in your approach in the way you conduct your research. So you can't really be rigid. So you really have to think about pragmatic approaches or pragmatic methods and study design that will allow you to look at different types of outcomes, that will allow you to look at pathways, that will link in different outcomes together, that will allow you to look at different way of constructing knowledge, either qualitatively or quantitatively and so on. So there's a lot of emphasis on very pragmatic designs. Even if you're doing something quantitatively, we talk about pragmatic trials in implementation research a lot. I had one example of that in my slide, but because of time, I may not go over that. But again, those four things are really cardinal to implementation research: implementation strategies, implementation outcomes, implementation context, and pragmatic implementation research designs. And this forms the core of implementation research, which is the core of implementation science. So I did allude to this while talking that, yes, context is really a driving force in prescribing what kind of research we're able to do, given what kind of implementation research we're able to do, given the way we've described what implementation research is. So context becomes the focus of our study. Even if we don't acknowledge it explicitly, it drives a lot of the considerations that we make in implementation research. So context is both the focus and the conduct. It influences both the focus and the conduct of our implementation research. And by context, we mean external context and internal context. So outer context and inner context. So external context, again, think political economy, think history, is history that governs a particular group of people, govern a particular society. Think institutions, institutional arrangement that governs systems, social systems, health systems, education systems, and so on and so forth. All of that is encompassed within the external context or within the outer context. And then the inner context is really more those settings that are very, very closer to the implementation arrangement. That is characteristics of the individual that is implementing, characteristics of the individual that is benefiting from the implementation, and the organization that they belong to, the community that they reside in, the healthcare delivery system for intervention that are delivered in clinical setting, and so on and so forth. So all of that are within the inner context. So all of these forms the focus. So oftentimes we are trying to understand the facilitators and barriers from a contextual perspective, or we are trying to overcome a particular barrier using an implementation strategy, or we are trying to replicate what works in a particular context under a particular contextual arrangement in another contextual arrangement. So you will see that context really affects our ability to systematically implement. It, of course, governs our implementation research questions. So a lot of the questions that we would be addressing in our research will be emerging from the implementation problems that are prescribed by the context. It also affects the choices of theories and the models that we use to explain relationships along the implementation pathway, and again affects the kind of study designs that we will need to use. And all of these therefore have implications for what implementation researchers or what implementation scientists should know, the kind of competency that they should have. I did mention earlier on that implementation research ideally should be team-based. So a lot of these competencies should combine competencies from different members of the team in order to successfully conduct our implementation research. This is really just to highlight how context really comes to play, and when we begin to think about resource limited, low resource setting. And in low resource setting, oftentimes this is really just looking at how health system influences implementation research. And by health systems, I'm not just talking about the hospital or clinical care delivery arrangement for providing health services. I'm talking about all of the actors and all of the people and activities that are really working together to ensure health for a group of population. So it involves policy to provide oversight on the clinical services delivery system. It involves input management, both information, pharmaceuticals, and supplies. It involves financing, even financing that is external to the clinical providers and so on. And it involves larger contextual determinants of those health system components. So the norms, the history, the education, and so on. So, and in low and middle income country setting, as an example of low resource setting, a lot of these health systems components are really underdeveloped. So oftentimes we have weak oversight, weak governance, we have weak service delivery system, we have insufficient input management, we have insufficient financing, and so on and so forth. And these really influences what you are able to do, because there are a lot of things that we are able to do in high income countries or in high income setting that we are not going to be able to do in such setting where some of these things are lacking. So for instance, when I'm doing implementation research in the US, most of the time, I'm going to make some strong assumption, that the system works, that the insurance company is going to pay for benefits, and all of those things. Those will probably not form where I will foresee implementation challenges, and I will really be thinking more on the nitty-gritty of my implementation activities in the clinical setting or in the community setting in which I'm working. But when I'm working in a place like Ethiopia, or I'm working in a place like Nigeria or in Kenya, there is no guarantee that all of this policy is in place. There is no guarantee that there is a structure in place for financing. There is no guarantee that there is a structure in place for managing input, both information and other things that is needed. So oftentimes I would have to create those resources, or I will have to target some of my implementation research questions on those higher level health system components. And this is where you begin to see that working in a low resource setting requires you to do more. It requires you to look beyond just within the immediate environment of the implementation, because you have a lot of factors that are going to influence what you're able to do, and therefore the kind of research question you're able to answer. This is really just to illustrate that. And like I said, even though we've illustrated this, speaking from a low and middle income country perspective, again, low resource setting is not limited within countries. In US, where I work, where I sit, we have a lot of low resource setting in the southeastern region of the United States. And I will give some examples from in terms of some of the case studies that we've done, so that we can see that, yes, all of these, as long as this principle abounds, the approach for doing implementation research can be carried from one low resource setting to another low resource setting. So again, this is highlighting yet that the way context can shape things. This is looking at money, political economy, and we can actually see how diverse in terms of the map of gross domestic product per capita in 2024 is, from places like Europe, Switzerland, and the United States, Scandinavia, to compared to places, countries within Africa. And if you can imagine that these economic resources is going to influence politics in all of this setting. And therefore, places where you have economic constraints, there is yet a wide variety of institutional and socio-political arrangements that needs to be made, even within those countries, in order to get to make things work. So again, this is going to shape your research question. It's going to shape the way you go about studying those implementation research question. If you're implementing things, it's going to shape, the actors that are involved, and the methods and the theories and so on that you will use to explore. So just to summarize a little bit, and I've been alluding to some of these in my description, you can now begin to imagine some of the challenges of conducting implementation research in a low resource setting, using a low and middle income country setting as an example. We did some studies some years ago, and we looked at all of the research that were done in countries that were delineated, classified as a low and middle income country. And we were able to see that, yes, indeed, it wasn't just only on paper or in theory that context can constrain, but actually in the way some of those research studies were done, cutting across studies done in clinical setting, community setting, studies done on various topics from maternal and child health to tropical diseases to HIV prevention and so on. All of them were similar in the sense that for those that were done in LMIC, there is always a limitation in the capacity of the health system to support systematic implementation, to support learning, to support implementation research. And therefore, there's a lot of burden on the implementation scientists to work with stakeholders to create some of these resources in order to be able to implement in the first place, so that they can then do research around those implementation. And there's also with data systems, apart from limitations around the systematic implementations of intervention. The data system that are routinely collected in high-income country setting for monitoring demographic and health outcomes are not available. So oftentimes you have to set up those infrastructure, set up your own data systems in order to conduct research. And of course, this comes at an higher cost. And because of all of these variations in institutional arrangements, socio-political arrangement, in actors and systems, we often find that a lot of the theories and the models and the frameworks and the methods that we've used extensively in high-income country setting, like in the US, like in UK, or in places like Switzerland and so on, they don't transport to low and middle income countries. So we really have to think more about those settings and adapt those theories even to fit those settings. And of course, I've mentioned some of the issues around governance and how that can impact on our implementation activity. So in that study, we kind of teased out what people who work in an high-income country setting, what they feel is lacking in implementation research that is originating from low and middle-income country. And a lot of this is formed by the bias of where people sit. So, people in high-income countries, they sit at a vantage position, even though we don't acknowledge it, but the system works largely to an extent. So, but we don't acknowledge that because we don't know what we are not lacking. It's really when something is lacking that we begin to become aware that, oh yeah, we take a lot of things for granted. So for those folks, when they look at implementation research coming from a low and middle income countries, oh, criticism is always, oh, it's not robust enough because maybe they didn't follow use strong, robust design in quote, like trial design and so on and so forth, that we actually place a lot of premium on. And maybe there are issues with the internal validity of the studies and so on. And it's not methodologically sound. And therefore, there's also this tendency to think that it's poor quality. And because it's poor quality, it might not be ethically compliant, given the burden that has been placed on the research subject and so on. And the same, we some years later back, we kind of looked at flipped the side of the coin to think about, from those who are in low and middle income country, what did they think about implementation research for my income country? And you can imagine, you can hazard the guess that a lot of the conversation was really around the lack of attention to health systems. That is really because in high income countries, their system is pretty robust and resilient to some extent. So the question of for implementation is really more proximal to the intervention. But for those who are in LMIC, the health system is the challenge. The health system and the policy environment is really the challenge, and mitigate or researching around that becomes a goal. And there's also criticism that there's lack of equity, focus on equity and ethics of conducting things in such setting, and that there are a lot of things that is needed that is not talked about to work in such settings. So things around soft skills like communication, knowing who to talk to, knowing how to advocate, knowing how to talk to leaders in a way that resources that you need to implement and to do research is released, and so on and so forth. These are skills, these are competencies that you will need if you're going to be working in a low and middle income country setting. So it's not just sufficient for you to be a researcher. Amongst your team, you have to have people who can communicate very well. You have people who can understand the ethics of the culture in which you're working in. You have people who know the policy environment, who can take advantage of the policy windows that may open for implementation, and so on and so forth. So you have to know how to leverage resources. So to conclude this part of the presentation is really just to think about, in all of these, what are some of the strategies that we have identified over the years, given some of this research that that it seems that I have led and so on. There are at least 5 things that I would like to leave you with to consider if you're going to be doing implementation research in a low and middle income country. One is that whatever research that you are doing, whatever implementation research that you are doing, you should be thinking about creating resources. Whether you say that explicitly or not, it really should be part of your research specific aims in some regard. So, and there are strategies around that. So creating resources around human resources, for instance, tax shifting and so on, teleeducation, using technology to bridge resources gaps and so on, should be under your consideration. And you should also be thinking about changing behaviors. That is to say, trying to give people the skill set in order to utilize resources more efficiently in the delivery of evidence-based practices, evidence-based interventions. And again, so thinking about training, supervision, providing learning collaborative model where exchanges can happen. It's really important. And then, of course, innovation is key. So you really need to think about innovating around your methods. That is to say, what method is fit for this setting, and methods around participation, participatory approaches, methods around that focuses on people, methods around group modeling, that is building things together, is really important, is key, because for you to unlock the knowledge of the barriers, the knowledge of success for implementation, you need to bring all of these people together. And then also, similarly, you need to be creative in your strategies that you use to deliver your intervention in such resource poor communities. So again, and you can't do all of this without building capacity. So your research objectives, your study objectives should always encompass capacity building around how to learn and how to continue to improve the system and also improve delivery of your intervention. So again, these 5 principles are really key to doing research, implementation research in low and middle income country setting. And these are some of the strategies to consider. So I'm going to pick it up a little bit because of time. So for this last few slides that we have, we've talked about what implementation research is. We've talked about what distinguishes implementation research and what characterizes implementation research. We've talked about what implementation research looks like in low and middle income country setting relative to an high income country setting, but extending to low resource setting. We've talked about some of the challenges of working in such low resource setting, and we've talked about some of the strategies to consider as a researcher, as a scientist, working within a team in doing implementation research. So let's finish it up by looking at equity. That is to say, in all of the things that you do in implementation research, equity should form a goal for particularly if you're working in low resource setting. The intentionality to work in a low resource setting is really an implicit or an explicit acknowledgement of the need to address equity. And that's true. We know that over the years, in the last 20, 25 years or so, since implementation research has really become very popular, implementation research has contributed to a lot. I mean, it has really helped a lot to address knowledge on barriers, facilitators, strategies for implementing interventions in global health. And we've seen a lot of improvement from reduction in maternal mortality, infant mortality, and so on and so forth, as a result of effective implementation of evidence-based intervention, in global health. But in spite of this improvement, what has persisted is the inequalities where you compare outcome of looking at different population groups. So this is really just a slide to exemplify that, looking at access to maternal interventions by socioeconomic status deprivation index. So you will look at the slide really shows box plots of certain indicators or outcomes of maternal care, looking at family planning, access to ANC, skill birth delivery. You will see that when you compare column to column, that is low income, low and middle income, and upper income, the access is always higher in the region with higher socioeconomic status. So upper income, low income, upper income is greater than low middle income, lower middle income is greater than low income. So that is just looking at regional disparity or even between country disparities and so on. But even within country, so if you just focus on one of the column, not the three columns, just focus on one of the column, one of the slides, you will say even just within a low income country, between those who are categorized as deprived, vulnerable, and not deprived, again, there's a gradient, in terms of the access higher in those who are deprived. So the point here is that even though things are improving from a utilitarian perspective, on an aggregate perspective, but when you look at improvement amongst different countries or regions or even different population within a country, you still find the disparity. And that's one of the reasons why it's really important to think about equity as you are doing implementation, or as you are as you're doing implementation, or as you're doing your implementation research. So when we talk about health inequities, I won't belabor this, but really it's for me to make a determination of health inequity, I really have to be able to show that there is some health inequality, that there is some absolute differences in some indicators of health comparing different population groups or individuals. But that in itself is not health inequity. For it to be health inequity, those differences have to be undergirded by differences in some social determinants of health, that is the way people live, work, and practice their religion and live their life and so on, and also structural determinants of health, that is differences in the structure that undergirds the social determinants of health. Think system, social system, employment system, labor system, justice system, education system, and so on and so forth, that undergirds the social determinants of health. So differences. So if some people have an advantage over other people with regards to structural determinant, with regard to social determinants of health, and this is linked to differences in health indicators, which can be described as indicator of biological factors, mortality, morbidity, or social factors, things about mental health and so on, or behavioral factors, factors, and or even services, access to services or services delivery outcome. That is inequity. It's inequity when it's unjust, and when it's linked, undergirded by structural determinants of health, differences in structural determinants of health and social determinants of health. So, and we really have to acknowledge, like I'm saying, that whether you say it or not, when you are implementing health intervention within in a low resource setting, you are going to be interacting with the distribution of health factors for providing health services. You're going to be interacting with the resources and the structure and power that undergirds the distribution of those resources. And that's going to impact health inequity, whether you acknowledge it or not. So this is really just to show that. And this is saying that we have to acknowledge that implementation in a low and middle income country, when we go from Europe or go from the US or go from some other place and we go to another place, it's okay, we want to implement, we want to help disadvantaged population. If we are not paying attention to matters of inequity, whether or not we acknowledge it, we are going to be either worsening the inequities in those settings or improving the inequities in those settings, because our implementation arrangement is going to interact with the distribution of health services, is going to be interacting with resources available for that, and therefore it's going to be either ameliorating those inequity gaps or reducing them. So what are some of the ways to think about if we're working in low resource setting or working to address inequity, how can we leverage implementation research to do that? There are three pathways that I would discuss today. One is to think about application of equity-focused implementation research theories, models, and frameworks. I believe in subsequent presentation in this series in the next couple of months, we are going to hear from other people who are going to talk exclusively about some of these theories, models, and frameworks. But what I just really want to show to you today is that there are specific theories or models or frameworks that are helpful to learn how inequities can emerge or how inequities can be addressed from an implementation research perspective. And I think using those, applying those can help. And I will show you an example of how that can be done. And secondly, you can also design your implementation research purposefully to address health equity. And this is to say equity can actually be your primary objective for conducting your implementation research. And therefore you are studying implementation strategies to bridge inequity gaps. And there are some examples of such strategies, which I will again discuss. And then finally, if we have time, we will talk about how you can build partnership, particularly linking resources from a high-income country setting with low and middle-income country setting in order to advance equity goals through academic partnerships. So to apply equity-focused TMFs, theories, models, and frameworks, there are at least three main ways by which you can do that. You can use you can select an implementation research theories, models, and framework to explore the social determinant and structural determinant of health as it affects the implementation for the evidence-based intervention that you are looking at. So as part of your study, where you're looking at facilitators and barriers, which is something that we often do as part of our implementation research, your examination of facilitators and barriers could also explore social and structural determinants of health that undergirds the implementation. And that could be informed by some dedicated theories, models, or frameworks. And again, you could also use TMFs to identify what implementation strategies is relevant for addressing contextual factors that may affect socially disadvantaged population. And then there are also TMFs that we can use to specify implementation outcomes as part of our implementation research, implementation outcomes that will specifically target impact of interventions on health inequity. So, as an example, this is one example of an implementation research theories, model, and framework. So this is an health equity implementation framework, which is based on the Paris model, for those who might be familiar. But basically what it does is that it's actually explicates the context. It explicates context, both the inner context, think about patient factors, clinician factors, characteristics around the innovation, and the external context, socio-political forces, physical structures, and economics, and so on. And it shows how, if you consider factors within those inner contexts and the outer context, and if you facilitate around those factors, that if you create strategies around those factors, you are not just only going to be able to be successful in your implementation, but you also be successful in addressing inequity. So this was applied in rural United States. So in the rural part, which is an example of a low resource setting, I intentionally wanted to show this, that again, this is not bounded to low and middle income country settings. So there was in southeast region of the US where I work, veterans, those are army people who are retired army officials or retired military personnel. They are disadvantaged because they lack access to basic services. And there was a study that was done to look at how treatment for hepatitis C virus was being received, looking at different racial groups among these veterans, among these retired military personnel. And they discovered that even though there was a very effective intervention, direct acting antiviral for treating HCV, but there is less uptake of these treatment comparing Black patients, that is African American patients, to white patients, and also comparing people of different other social demographic group. So the question was, how do we do this? So they took the HEIF, the HEIF framework, to actually understand what are the barriers that are being faced by Black veterans, including barriers in their social determinants of health, barriers that is influencing their social determinants of health, and so on. And they use that framework to actually specify strategies, and they package those strategies along with the strategies that they are already originally designed for delivering the intervention to actually show that you could actually succeed in your implementation and at the same time help improve outcome for specific groups in a way that it reduces the inequity gap. So again, they did this using a mixed method study. So this is really just showing that you could actually use those TMFs for the purposes, and there are different examples. So this is again a classification. You will have access to the slides. These are different types of theories, models, and frameworks classified based on what they do, either looking at determinants of implementation or trying to explain implementation theory or trying to look at steps by step to guide you in implementing in a way to achieve equity, or trying to evaluate an implementation arrangement to see whether it addresses inequity, or combining any one of these classifications. So the second approach, I'm wrapping up now. In the next 2 to 3 minutes, I should be done, is really to design your implementation research to address health equity. And that is to say that when you are going to implement something and you are formulating your team, you can intentionally design your intervention to address health inequity. And there are considerations that you can make. Those considerations really is governed by the understanding that there are power asymmetries between the implementer and those who are benefiting from the implementation, between other groups within the population. And you have to think about those power asymmetries in the process of your implementation. And there are 4 or 5 considerations or principles that you can use in your design. So when you're prospectively designing a study, in addition to all of the things that you are doing, you are making sure that for the health problem that you're trying to address, you are defining that health problem as also as an health inequity problem. So you're not just looking at, there's high mortality among this group, but you're thinking, what are the health problems for different subgroups within the population? So you're describing the health problem as an health problem and also as an health inequity problem. And when you do that, then you're also involving stakeholders that are disadvantaged in defining that problem. So you're involving those vulnerable groups in defining their problems, in also specifying what else supported intervention, ESIs might be helpful, and also in the implementation process. So you're thinking participatory processes. You are building design together and figuring out strategies and solutions together. And in all that you do, in addition to every other thing that you're going to do as part of your research, you are adapting your implementation, your interventions to the inner context of implementation. That is to say that you are thinking about the beneficiaries, you are thinking about the implementing organization, and you are trying to figure out, are there things that we can do differently in addition to all of the arrangement that we are making for the implementation to address inequity. So for instance, if I'm delivering a services in an healthcare setting, and if I'm going to be intentional about designing my study for addressing inequity, I would think about, are there existing policy within the healthcare delivery system that specify we should not discriminate against people of certain group? Is there a way to promote the enforcement of those policy as part of my implementation arrangement, even though that's not the primary subject that I'm interested in, but since this is already on the books, can I incorporate that as part of the strategy that I'm going to use, so that at the end of the day, I will not just only see improvement in my clinical outcome, but I also see improvement in my health inequity outcome. And then, of course, you are using relevant design that allows you to flexibly study those outcomes of implementation as it pertains to vulnerable groups compared to other groups, the health outcomes as it pertains to vulnerable groups compared to other groups. So again, it's recognizing that when you make those considerations in your design, you are going to be impacting positively for equity gain in your inner context, and which is, again, has some spillover effect to the outer context, which then influences the extant inequity that may exist in the population. And all of this, again, is undergirded by power asymmetry. So, I mean, maybe during the discussion, I will have more time to explain this. And so that you can do this not just only prospectively, but you can also do it retrospectively. That is to say, you can, for things that have already been done, or maybe you've already embarked on your studies, or you've finished the study, and maybe I didn't pay attention to equity in the first place. But how can I reflect on what I've done to consider whether or not I've helped to address inequity or I've worsened inequity? So there are, again, considerations you can make. For instance, you can evaluate for all of the evaluation questions that you might have, you could ask an evaluation question around, who eventually is benefiting most from the intervention that I delivered, broken down by different population groups, and then have there been any asymmetries within the inner context of the implementation organization? That is to say, for instance, that there are issues of gender dynamics that have worsened or that have improved, within the implementing organization as a result of my implementation activities, and whose perspective is shaping the evaluation. That is, did I consider the perspective of the vulnerable population, or did I consider the perspective of the disadvantaged population in specifying my evaluation? And then did I actually look at the impact of my implementation activities on the social determinants of health, on the structural determinants of health? Again, the loop is governed similarly as we described. So finally, these are some of the strategies in your design of designing your study to address implementation, to address equity as part of the implementation research. So there are strategies that you can consider as incorporating into your study to address the mechanism of health inequities, particularly to address how differences occur in either access to services or in outcome of specific health outcomes. And this borders around things already that is established within the inner context: training, tools to address bias, enforcing anti-discriminatory policies, and so on. And also there are strategies to consider to address the social determinants of health as part of your implementation research design. So things around access to income, access to health, access to education, and so on. And there are also things to consider to address the structural determinants of health. That is, looking at the systems that governs the social determinants of health that govern your implementation arrangement. And of course, there are strategies that you can also use to deliberately shift the power asymmetries that may exist between implementers and beneficiaries that can be incorporated as part of your research. So this is really just the last way to leverage implementation research for addressing inequity. And it's really, simply put, is really to come together, I mean, building consortium or a partnership between a high income country setting and a low and middle income country setting. Similarly to what, for instance, the Swiss Topical Institute for Public Health does. There's a lot of connection from an high income country institution to a low and middle income country institution. And we really found out that is one effective way to address inequity, because invariably you are sharing resources amongst each other. This is an example of a project that I've been leading for the last 7 years or so, which is really focused on polio eradication. We had a consortium of countries, institutions from over 6 or 7 different countries, and looking at how do we learn together and deploy implementation strategies together to support the elimination of polio in specific regions. And of course, we use implementation research designs in theories models to actually guide our methods and our analysis in order to address issues around inequity. And we're also intentional in looking at inequity as pertaining to polio outcome itself, or as pertaining to services related to polio, and also inequity within the implementing organization that are looking at eliminating polio. So we're looking at things around gender dynamics, equity dynamics within the implementing organization, within county health system, within clinical settings, community setting, around the implementers and so on. And also, we also reflected on ourselves, because we had a consortium of institutions in the US, in Indonesia, in Nigeria, in the DRC, Ethiopia, and so on. What are some of the things that helps us to communicate and work effectively? What are the things that hinders our bi-directional partnership? And we're able to identify some of the criteria to do this. So it includes things around setting transparent agenda, really being transparent in the resources that we can share, setting expectation, really providing a communal access to resources. So for instance, whatever is available to one, we share it with the rest of the group as much as possible, and really putting money and resources in building relationship. It's not always about the research, it's also about building human connections and so on and so forth. So again, this is really just an example to say that formulating bi-directional academic partnership could actually form a bedrock or a platform upon which you can then layer every other set of activities to use implementation research to address inequities in low and middle income country setting and in low resource setting. So I know I've spoken a lot, but just to conclude, to say that there are principles for conducting implementation research globally. And of course, these principles, they are universal globally. However, the context constrains this principle as you move from setting to setting, as you move from a low resource, high income country setting to a low resource setting, particularly low and middle income country setting. And therefore, if you're going to be doing implementation research in low resource setting, you should be thinking about strategies to overcome the low resources. So thinking about creating resources, the innovation around your implementation and method, thinking about changing behavior, building capacity. And implementation research that is targeting low resource setting, whether it acknowledges it or not, is actually contributing to either reducing inequity or worsening inequity. So you have to really be systematic in using your implementation research to address inequity when you're working in low resource setting. And there are ways to do this. You can apply equity-focused implementation research, theories, models, and frameworks to guide your project. You can design your project intentionally to address inequities, and there are strategies that we've discussed on how to do this, either to address the mechanisms of inequity, the social and structural determinants of that, and some of the power asymmetries. So again, all of this can be catalyzed by bi-directional global academic partnership, which actually helps not just only to address health inequity, but also to advance the field of implementation research and global health globally. Thank you so much. Sorry that I overshoot by maybe 5 or so minutes. This is really just to show you some of the things that we are doing here at the Sparkman Center at the University of Alabama. For those who are interested in learning more, particularly around how to use implementation research to address health inequities in global health settings, we have a summer season that we run, and you can get in touch with me if you want to learn more. So thank you so much for this time. I really appreciate the opportunity to speak to the Impact Network, and I'm looking forward to your questions and discussion. Over.
Thank you very much, Kunle, for what I think was a truly great and very inspiring presentation. You've given us plenty of food for thought, I think, and reminded us about the importance of remaining aware of health inequality, not just in low and middle income countries, but especially also in high income countries. And I thought it was very inspirational how you address it with targeted implementation and research. So we now have some time for Q&A, and what I'll do, I'll take the questions in the order they appeared in the chat, and rather than reading them out aloud, I would like to give you the opportunity to unmute yourself and to ask the question directly to Professor Alonge if you want. So the first question that we have in the chat is from Anna Bergström. Anna, do you want to ask the question yourself? Do you want to unmute yourself?
Sure. Thank you so much. I actually, two questions. I think that one of the things an issue that I find anyway, is that the agenda when conducting implementation research in low and middle income settings is that the agenda is very often set by NGOs, external funders, etc., to an even higher degree than what's happening in high income countries. So I was just wondering if you have any perspective on that, because they want to sort of what people would like to implement and want to improve might not necessarily align with the priorities of those funders. And that I think is a huge problem. Second, I was just wondering if you have any good resource on how to make proper and good adaptations of EBIs. I mean, we speak about it a lot in high income countries, but given that there are so many other types of challenges that these EBIs meet when they also are adopted into guidelines, or they are adopted into guidelines, national guidelines, LMICs as well, but they're not taking these issues into considerations in a good way. So I was wondering if you have any good advice on resources. Lastly, and this was more of an advice to everyone, because I do think it's good that we use theories, models, and frameworks, but just as you said, they are developed for other settings. And when they are applied, very often I lack people critiquing them so that we can also build and see how valid are they when they are also taken to these other settings, and how can they be built and improved to actually also include some of these aspects that we see. Thank you.
Super. Thanks a lot, Anna. These are really excellent comments and questions. And I couldn't agree with you more that oftentimes there is a lot of arrogance, in quotes, that takes place when we are setting agenda. We kind of assume people in a low resource setting or people in a low and middle income country setting, we don't acknowledge them to be at the table when we are setting those agenda, and it's really one of the reasons why some of the things that we do don't work as we want them to work, and I think it's really around this idea of bringing those people to the table as a strategy for addressing inequities is some of the things that we've been talking about, and I think it's some of the things that we should take away with us from here. That yes, you might have the resources, yes, we might have the technical know-how also, but there's a lot of implicit knowledge that is about implementation, about context, that people who are closer to the problem, they know, and they should, not part of the agenda originally, they should be consulted, and their views should be incorporated as agendas are set and so on. And I think there are methods for doing that. So there are new methods that are there's a lot of emphasis on participatory methods in implementation research these days, not just on the participatory methods in setting objectives, but participatory even in doing the method. So there's participatory statistics, participatory epidemiology. That is, you actually people are not just only the subject of your research, but they are also they are researchers as well as part of your research and so on. And there are things around group modeling methods that we use, to understand implementation problem that brings stakeholders together, theory of change, causal loop group modeling, and so on and so on in system science and so on. So there are methods that we can use, but you are absolutely right. And I think it's something that we should all take away with us, that if we are doing implementation research in low resource setting, we need to acknowledge people in those settings. We need to give them a voice. We need to amplify their voice. They need to be involved in the agenda setting. And if we did not involve them in the first instance, we can always correct that mistake by incorporating their views as we move along. So it's really, really important. And yes, again, there are tools for actually adapting ABIs. There are a number of frameworks to do that, and I'm happy to share that after this presentation. But there is a textbook that we wrote on dissemination and implementation science. It was in one of the slides that I presented. There's a whole chapter on that, which really talks about how to adapt implementation strategies, how to adapt implementation evidence-based intervention, and it also talks about it on how to do that in order to address inequities. So I will refer you to that textbook, and from that textbook, the textbook actually synthesized a number of frameworks to guide systematic adaptation. So you can actually see some of them, and I also send one or two through ITA and the team so that it becomes more readily available. And of course, yes, TMFs, we really, and one of the things I didn't talk about in my slide, we actually have a call right now. We are looking for papers because we don't have TMFs. So a lot of the TMFs, theory models and frameworks come from high income country setting. And we go to low resource setting, these things don't fit, right? But we don't have things coming from low resource setting, or those things are not published. They are not given room, in our publication. So that's one of the things we are trying to address. We have a current call in BMC, Global Health and Public Health. For those who are interested, I'm actually the editor for that particular call. We are looking at theories, models, and frameworks, interested in theories, models, and framework that originate from low resource setting. That is to say, these are authors from low resource setting. They know the setting. They figured out that, maybe CIFAR, Consolidated Framework of Implementation Research, is not working for us here. This works for us better. Please send those publications, because you are right, those things don't fit, and then we try to make them fit. And because people are so afraid to talk to us, sometimes they say, they are the ones that know everything. Even though they have more knowledge about what is happening, they keep quiet, and I think we need all of those voices to actually help guide the field of implementation research. But really, thanks a lot for your comments.
All right. Then the next question comes from Eshetu Engeda. I hope I pronounced your name correctly. Eshetu, do you want to ask your question yourself? In that case, please unmute yourself. And yeah.
Yes, sure. Thank you so much for the opportunity. Thanks so much, Professor Alonge. It was a very informative presentation. I am a visiting researcher at the University of Lucerne, Switzerland, from Ethiopia. My question is, given the current trends of budget cut by major funders, what does the future look like for implementation research, especially in countries with government has a little support because of other competing priorities? Thank you. Over to you.
That's a very contemporary question, Eshetu, and I actually think implementation research is in a better position than other types of research in global health. I think global health as a whole is under threat for sure, with the funding cuts. And when I say global health as a whole, I'm encompassing discovery science, I'm encompassing other types of studies that we do in global health, I'm encompassing service delivery and so on. But implementation research, because it's really trying to support implementation of something that we agree that we should be doing. I think it's a little bit well insulated, but the question is, how do we make it more accessible? How do we make it more mainstream for people who should know? So one of the things that we can consider is, for every activities that we are doing, there will almost always some budget for evaluating that activity. So for instance, if let's say we cut malaria, for instance, in the US, there's a lot of cutting that is going on. We're cutting malaria vaccine, cutting this, cutting that. But at least there's some things that we're still going to be doing, right? So let's say we cut malaria, we keep HIV. We cut pneumonia, we keep tropical diseases. For the things that we agree to do, there's still an opportunity for us to learn how to do that effectively. And oftentimes for those things that are retained, there's always some budget for evaluation. So the argument we make is that you can't evaluate, you can't wait after 5 years to say, okay, I want to see whether this thing works, or after 2 years, I want to see how this thing works. I really have to be learning as I go, and implementation research is the key to do that. So I think implementation research, because of its interdisciplinary and its multipurpose use, can actually be embedded into whatever version of global health that emerge. And I think it's really been systematic enough to think about that is key. And that's the same argument we make to governments in low and middle income countries. So for instance, even in Ethiopia, there is some money that they've kept for evaluation of public health programs. That money is sitting with the Ministry of Health. So you can actually talk to people in statistics and planning to say, okay, listen, you're going to evaluate this in 2 years, but let's be learning as we go. So let's do some operational research as we go. And that way, the implementation research should be sustainable.
Then next is Sabina. Sabina, you also had some comments and questions.
So I will just kind of ask one of my questions or more a remark. I'm Sabina Geest, University of Basel, and as you can see, also part of the Impact Network. And Kunle, first of all, thank you so much for your presentation, highly valued. Now, looking back, at implantation research, implantation science gained traction over the past decade. But if we look really carefully, we see that there has been a lot of benefit coming out of the experiences from low and middle income countries with community participatory research. And I just would like to highlight that, because it's not that we are kind of inspiring now low and middle income countries. We have learned tremendously. And so this knowledge circulation, I just wanted to celebrate that.
I agree. That's really a good point, that before implementation research became what it is, people in low and middle income countries have been generating knowledge and learning on how to improve, and particularly for participatory approaches, including community-based research. We've learned a lot. We've learned a lot around patient-centeredness, people-centered approaches. A lot of the things we're doing now in the US healthcare system, we learned it from low and middle income country setting. And that's all this notion around reverse innovation, that is, things that have worked in places where it's low resource, we're bringing them to high resource. But I think what is still missing is voice. So they don't, all of these good things that are happening, you and I know it, and maybe people in this network know it because we have colleagues, or we are from there, or we have colleagues that we are closer to and so on. But some of those things are not well received there's a lot of publication bias. They're not well received in mainstream global health publication as they should. And I think it's something that we can change, leveraging all of our networks together in terms of giving more voice for some of this work to be represented. Of course, those things might not be written the way I will write it if I'm writing from Johns Hopkins University or writing from University of Alabama, but we should have resources in place to help people write those things in a way that it could then become accessible to all. But you're right, we've learned a lot already, and we are still learning even some more.
And I will leave my second question because there are a lot of very interesting questions further in the chat. So Aita, just jump over my second one.
All right, thanks a lot, Sabina. So next on the list is Maxime Magnon. Maxime, do you want to ask your question yourself? And if so, please unmute yourself. And if you like, turn up the video and introduce yourself maybe briefly.
Thank you so much. So Maxime Magnon, I'm working for Roche Diagnostics, Medicare Affairs, so from the industry. And my question was, what about the partnership between NGOs, healthcare industry, and academics to support this implementation science research in low and middle income countries? This would be very happy to have the vision of our speaker. Thank you.
Yeah, that's important as well. So I'd use the bi-directional academic partnership as an example of partnership, and you're absolutely right that for some implementation arrangements, for instance, vaccines delivery and so on, the partnership should extend beyond just academics. But sometimes the challenges is that where values are different or where philosophy are different, then it becomes more challenging to form those partnerships. So for academic institution, the values are a little bit similar, even if they are in different parts of the world. So it's easy to bridge over the differences really quickly and then to deliver on the promise of the partnership. But when you have to bring NGOs with academics, with industry, then you really have to think critically about what are the commonalities, what are the common values or common philosophy that can undergird that partnership in a way that it would be successful for accomplishing the implementation goal. And you're right that if that's what we must do, particularly for some health problem, for some implementation problem, that is what we must do. That's exactly what has happened in polio eradication initiative. That is what has happened in elimination of guinea worm. So for instance, elimination of guinea worm, we had Carter Foundation, which is a large NGO in the US, working with USAID, which is a government entity, which is normal, working with some academic institution and working with some community group to actually eliminate guinea worm in the African region. So, but that's more challenging. Such partnerships are more challenging just because of the differences in values and philosophies.
All right, then the next question came from Yashashri Pokerel on equity. Yashashri, do you want to ask the question yourself? Yes.
Yeah. Thank you so much for the insightful talk. So I guess I'm posing a broader, more philosophical question here. So I guess we can use implementation research as an example. It's how we can truly build equity where, LMIC do not have to really depend on high-income countries, let's say, for example, in terms of capacity building, such as this, South-South collaboration, maybe just, local initiatives within the low-income countries in terms of, building capacity in implementation research.
Yeah, absolutely. I think South-South collaboration is really, really important, and even within the partnership that I described, for instance, the Stripe consortium that we initially started with a partnership from an high-income country to a low and middle-income country. But as the partnership matured, what emerged is that the South-South collaboration actually became stronger. So we had collaboration. We have people, institutions from India, Bangladesh, and Indonesia working more closely together than working with institutions in the US. So I think it's always beautiful if that emerges naturally, and it's often the case that because of resources that is available in high-income country setting, the partnership often always starts with an high-income country, low and middle-income country partnership, and once those partnership begins to mature, then the South-South partnership emerges. So yeah, I think it's really more of an issue of resources. So the resources is often flowing from a high-income country setting, and then it helps to build the partnership, and then the South-South relationship then emerge. But there's no reason why that cannot be flipped. Again, the question is going to be, can the resources come from the South? So the answer is yes, for sure. Those South-South partnerships can actually form the basis of those larger global academic partnerships.
All right, then Kate Molesworth, do you want to ask your question? Maybe briefly introduce yourself. So.
Yes. Hello, everyone. I don't know if my video has fired up or not, but anyway. Yes, I'm Kate Molesworth. After 18 years with the Swiss TPH, I'm now an independent advisor on public health in resource-poor countries. I'd like to thank Professor Alonge for the great presentation and everyone for the great questions, which I'm really enjoying. My question is shamelessly banging the drum for feeding back to communities, but I'd like to ask it anyway. So for me personally, working a lot in health promotion and attempts with communities to increase their empowerment to take control over their own health, I feel that health literacy is absolutely key, but it's often weak in some of the countries that we work, especially among poor and disadvantaged communities. So, Professor, I'd like to ask you if you'd comment upon how implementation research might contribute to strengthening health literacy among the communities that we're conducting research with, as a matter of course, how we might build that into our practice.
It's a lot for that interesting comment, and I completely agree that we need to feed back information to the community. And I think some of the ways to do that is along the lines of what we've discussed during the presentation. I think it really starts with the recognition that communication is a continuum. It's not something that we do at the end of the project. It's not something that we do at the beginning of the project or something that we do at the end of the project. It's a continuum. It's a conversation that we do at every phase. And that's really the principle that underlies the recommendation that disadvantaged population, vulnerable population, community should be involved in defining the problem, the implementation problem, in describing the strategies for overcoming the problem, in implementing those solutions and studying around them, and in learning from them. So if we observe, and that's really what implementation research espouses, at least for implementation research that is targeting health inequity, is really to bring every actor that is involved in defining the problem to the table, particularly the vulnerable population. And so invariably, people are learning on how to learn about their own problem without you saying, oh, come together, let me teach you how to communicate. The communication is happening organically because you've set up a participatory process across the continuum of the different phases of the project. And of course, once the results are out, because you've set up that channel, those channels have already been established and the platform have already been established. It's easy for you to say, okay, oh, how do we talk about this beyond even the us that have been looking at this together? And what has happened in our own experience that is actually the community people that tells you how to then talk about it. Even sometimes they say, oh no, let's just tell a story. Let's not, at the end of the day, because they know the problem. They know how we designed it. They were part of it. It's part of their research. It's now their work. So they know how best to talk about it. And I think it really starts with an acknowledgement that we need a paradigm shift, because we look at biomedical research from a investigator-led perspective. Oh, I'm the clinical investigator, I'm the PI, I know everything, so everybody do as I say, and shift that to a team-based approach. That okay, yeah, I may be more privileged because of where I see it, but when it comes to defining this problem, there may be other people that know more than me. So we all come together to share what we know. And then in describing the solution, we use the consensus-driven approach. And of course, where we need to do things rigorously, I say, hey, excuse me, no. We can't conduct the research like that. And I'll give my reasons. And then they would also feedback, and that's the way to learn. So it's kind of a bi-directional communication, and it's not a one thing or a specific time, or it's something that is continuous over time.
Thank you so much for highlighting the importance of meaningful partnerships with communities. I appreciate it. Thank you.
Thank you.
Then next we have a very concrete question from someone who is identified by Bravin, maybe not pronounced correctly. Do you want to ask the question yourself? If not, I can also read it. So the question was, what implementation research methods do you suggest or recommend for a project which is trying to measure the behavior change aspect among all older adults?
That's a very broad question. I wonder if you want to speak more, Praveen, on your specific objective for your research. But I will just comment that you can think about this broadly speaking around strategies, implementation strategies, whether there are specific implementation strategies that helps to implement behavioral change for older population. So that may be one way to cut it. But again, it's very hard to comment without knowing your specific objective. So I can think about it in terms of, are there specific implementation strategies that helps you working with older population, or implementing behavioral change among older population? And I can also think about it about, are there theories, models, and framework that helps me to figure out whether my behavioral change intervention is going to succeed. So there are a number of them. We have COMBI, capacity, opportunity, maintenance, and behavior framework. We have TDFs, theoretical domains framework, and so on, that can actually help me to look at my behavioral determinants and to kind of figure out what is most likely going to be an issue for older population and so on. Or it could be a question around the design, that there are ways to collect data or information targeting the older population and so on. So I think these are broad principles around strategies targeting your kind of intervention and the kind of population you are looking at. Broad theories, domains, and models and frameworks for guiding the implementation process, understanding the implementation process, and so on, and broad guidance around your methods for data collection, for synthesizing data, analyzing data, and so on. But these are just broad guidance. But I mean, if one knows your specific objective even more, then you can actually tailor some of these suggestions a little bit better.
All right, I think we're a bit at the end of the Q&A session. Maybe just to finish, I would like to point you towards the call for papers, which was put in the chat also, for which Kunle is the editor. So for submissions on TMFs that have been shown to work in low and middle income countries. So that's the place to go and see and hopefully submit your manuscripts. So with that, I would again like to thank you very much, Kunle, for a very inspiring and really great presentation. Yeah, so I think you have given us really all a lot to think about in our daily work in low and middle income settings and low and middle income countries as well. With that, I would like to point you, and I think there should be a slide actually, to the next webinar, which is upcoming for the Impact Network, which will be happening on the 7th of May. Yes, thank you so much. So the topic of this webinar, which will happen in a bit more than 2 weeks, will be Bridging the Gap, Implementation Science Solutions in Practice with a focus on cardiovascular disease. And I'm looking forward to seeing as many as possible of you on that occasion again. With that, I would like to thank everyone participating, discussing during this webinar, especially to Kunle, but also to all participants who had very important and good input, a lot of very relevant questions. If you want to have a look at our, the webinars that happened in the past, please use this QR code. Webinars are also published on YouTube. So we would be happy if you would have a look at those. I would also like to highlight the 4th Impact Swiss Implementation Science Conference, which is planned for the 12th to the 13th of February, and which will be happening in Zurich. So please look out for registration and hopefully again, see as many as possible of you at this this science conference, implementation science conference. Sorry about that. So with that, I would like to again thank you everyone, and I wish you a very good rest of the day and a very nice and relaxing Easter days. Have a good evening, everyone.